12, and we'll talk a little bit more. Anything that has carboxylase in the enzyme, so propenyl-CoA carboxylase, 3-methyl-crotonyl-CoA carboxylase, all the carboxylases require biotin. I don't think, although you can correct me, there's no one with holocarboxylase synthase here, right? No, all right. And then the last one's the thymines, another cofactor that few think about. All the dehydrogenases require thymine. So this includes the dehydrogenases that cause MSGD, this includes IVA, so thymine. So some individuals will require supplemental thymine. This also includes pyruvate dehydrogenase. Okay, research. You're going to fix the enzyme function, and this is by enzyme replacement, gene therapy, RNA therapy. You're going to hear lots about this in the next. So, all right, so we're going to talk about some specific disorders. Now remember, every patient is different, so there's going to be some variations in specific. Every one of these lists are coming off a set of guidelines. They're almost all the European guidelines. At the end of my slides, I will tell you where you can download your own copy of those documents. Okay, so first of all, in the acute setting, because we've got acute and chronic, it's reverse catabolism by the typical ways, right? And then there's a question about whether you hold protein for 24 hours or not, and this has to do with, are you loading the stream up? Are you preventing extra toxin formation? The reason there's actually a question mark there is if you haven't been eating for 24 to 48 hours, you may have already done that yourself, all right? And so you may have already held your protein for 24 hours. Scavenge the toxins. This is carnitine, ECMO dialysis if necessary, nitrogen scavengers if necessary, and you can try biotin. Very few are responsive to biotin, but you can try it. In the chronic side, avoid prolonged fasting, which is a fancy way to say don't get into catabolism. Protein restriction with supplemental non-propiogenic amino acids. It's pretty vague, and the reason it is because this actually comes from the European guidelines, and every country in Europe has slightly different access to different things. So it's vague by definition. There's some recommendations of WHO minimal requirements for protein. I didn't want to go into all those details. Everybody should be on level carnitine. Nitrogen scavengers may be of a benefit, and you need to screen and utilize standard therapy for the underlying long-term complications. What does this mean? It means an annual eye exam and at least an annual cardiology exam. Echo and EKG are both recommended. In addition, there's also some neurologic screening that's recommended depending on what's available. And then maybe liver transplant. In those who meet the clinical criteria, and it's clinically available in the sites that they are. And that was potentially the biggest argument because there's not equal opportunity to access for liver transplant in Europe. If you're in Italy, you're going to get transplanted. If you're in France, you might get transplanted. If you're in the Czech Republic, you won't get transplanted. Therapies for MMA without homocystinuria. Okay, so again, reverse catabolism, potentially hold 24 hours, scavenge the toxins. Everybody earns a dose of cobalamin, and this must be hydroxycobalamin, IM or IV. Okay, no cyano here, it must be hydroxo. And it's in the guidelines, and you'll see the next set for the cobalamines, it's in those guidelines. It's almost the exact same list, screening. This includes screening for renal dysfunction and maybe a renal liver transplant, and the reason that that's the case is because of the inability to access in all sites. So there also were a set of guidelines that came out for the remethylation disorders, cobalamin C, D, E, F, G, J, and MTHFR. All right? Now why these got grouped together is because they grouped all the cobalamines together and they grouped MTHFR because C and D also have methylmalonic acid as a component to it, but has homocystinuria, and MTHFR, and that severe MTHFR, no enzyme activity, which is different than the common variant, presents with homocystinuria in the 300 to 600 range, with the normal homocysteine being less than 12. All right, so therapies for cobalamin C and D1. Reverse or prevent catabolism, avoid dehydration. They actually don't specifically say how to do this. They just specifically say this. They say hydroxycobalamin, IM or IV, and it's hydroxycobalamin, and there's a big discussion about why you don't use other forms, plus or minus levocarnitine. Hydroxycobalamin in the chronic, and that's for those of you who need an NDC to get it covered. That's the 1 milligram per mil. I know some of you are in higher concentrations, but for those of you who are having difficulty with your insurance to get it covered, there is in fact an NDC number for hydroxycobalamin. For those of you who have no idea what I'm talking about, so when you say I'm doing vitamin B12 shots, some insurances won't pay for it. If you're able to give them an NDC, which is a true pharmaceutic number, you can actually sometimes get it covered. As I said, that is the 1 milligram per mil concentration. I recognize that some of you are on compounded things. And then betaine. Betaine's trade name is also known as cystidane. It helps scavenge that the extra homocysteine and help converts it to methionine, which is a little bit beyond here. It's interesting. There is no literature that has proven benefit for folate, folinic acid, L-carnitine, or methionine, or there's inadequate literature. So what does that mean? So in rare diseases, they're rare. So that just means that no one has done a study with large enough individuals to show that those particular therapies, which are commonly used in cobalamin C and D1, are a benefit. That does not mean a particular individual does not have that. The other thing here is avoid nitrous oxide. That's laughing gas. Our dentist might use it. The reason it's used to avoid in this particular disorder is it increases your homocysteine level and can lead to blood clots.
But that's just in
cobalamin C and D1.
Because Melissa just had it not too long ago.
Yeah, that's just C and D1. In fact, it increases all of our homocysteines when we have it. But usually, if you can metabolize it, it's not a big deal. All right, IVA. So IVA is actually fairly contentious, and this is actually the only quick reference guide. And in fact, they never got a publication because not everybody agreed with therapy. But in general, it's going to look a lot the same. Reverse catabolism, rehydrating calories, decrease protein for 24 hours, and scavenge with levocarnitine and glycine, right? Chronic, now it's interesting, they say protein restriction. Many of you may not be protein restricted at this point, and using the scavenge with levocarnitine and glycine. Every patient is different. They never actually published this because not everybody agreed, and there wasn't a lot of data to point one way or the other. GA1. This is actually really old recommendations. This is 2011, and notice it's actually the revised recommendations. There was actually an earlier form of this. And so therapies for GA1, treated aggressively and early, illness, surgery, immunizations, reverse catabolism with dextrose and electrolyte fluids, scavenge with levocarnitine, and treat fevers aggressive. Chronic, sequencing is actually helpful because of the low excretors. And then there's a lot of wiggle room here in the diet stuff. Remember, it's 2011, it's before your publication. And so it's a low lysine diet, plus or minus a metabolic diet with lysine free, plus or minus low tryptophan formula, up to 6 years. It doesn't talk about the arginine supplementation. Levocarnitine, glycine, and if surgery, please have a plan. What's most important, I think, is something that we can all use. This is actually what do you, as the caregiver and as the patient, need to know, right? This is one of the best I ever seen. One, know your disease. Be able to explain it. Know that you're the expert when you walk in the room. Inform and educate your local hospital, right? Let them know who you are. Inform and educate the ER. Have an ER letter with what they're supposed to do in the first 5 minutes, and also have it say something to the effect of needs to be seen now. If you're going on vacation, like if you're not from Minnesota, know who the metabolic specialists are in your area and your hospital, right? if possible, and you're going to be there for a period of time, or if you know you're going, have an introduction to the metabolic specialists so that they know if you were to get sick, who you are and where you're coming from. And then call your metabolic provider. And I'm saying providers here because like we have a nurse practitioner who does all our newborn screening. And so not just your doc, but your provider. Every fever, if you've got vomiting or diarrhea, if you're gonna go have surgery, if you're getting your tooth out, anything that's planned, anything that's not planned, because you're gonna want a protocol. So it's not hard for me to write you a surgical protocol if I know you're going to surgery in 2 weeks. It's a little bit more of a struggle to get something done right now if you knew you were going to surgery 2 weeks ago, but now are calling me because you're sitting with the anesthesiologist. Now, emergency stuff, I can get emergency stuff and we can get started without a problem. But like, if there's a planned procedure, it's so much easier if we have a plan. Okay, this moves us on. So what was the thing I said in like IVA and GA1 is, why do we need registries? Well, if anyone's ever seen guidelines, we kind of lock everybody in a room and have them discuss the literature. Well, if there is no literature, it becomes expert opinion. And so why do we need registries? Well, one, it's a rare disease. Before you were involved in OAA, had you ever met someone with the same rare disease that you or your family has? So no one in the institution has more than a few patients, excluding Holmes, who has a few patients. But like, how many times are you one of the few people that have whatever the disorder is? So I is taking care of a number of patients, and we have a very large cohort of metabolic patients. And not going to see more than a few, right? So how do we figure out what's best for a cohort that's much bigger than a few? Disease management has really been trial and error. Let's put it, that's how we got guidelines, is trial and error. Now, we've been really successful, and people like Steve Kohler and Holmes Morton have made us very successful. But it really was because we tried something and it worked, and we taught our students how to do it, and they taught their students how to do it, okay? And understanding the disorder is based on rare, unusual, or really frequent and or severe complications and presentations, right? It's what makes it into the research literature. The common PA patient doesn't often get published. And the above guidelines, all of them, are based on expert opinion for the most part, because there just isn't enough people to have evidence. So there's also more than one kind of registry. So there's the registry that Chuck and Irene and Oleg and Jen do, which is a deep dive. They have a few, I know you guys have a lot, but a few where you look very deeply and you spend a week and you get analyzed really, really deep. Okay? That's kind of the MMA registries or natural history. There's also some less specific registries. These are the European registries predominantly, where you have many, many patients where when they get enrolled, their doc puts in their information into the registry after you've consented. But it's really looking at how many patients. So the European Intoxication Network and Registry for Intoxication and Metabolic Disorders, which is what PA, MMA, IVA, and GA1 fit into. The cobalamines fit into a different registry for them. Has about 350 PA patients in it, has something like 120 IVA patients, and I haven't looked at the GA1 numbers. So less specific, more patients. And last, which is our registry, is patient-driven. It's what's important to you. Now, the goal is so that what's important to you becomes what's important to me as a caregiver, right? And helps me say, oh, these are targets of things I need to do to take care of your patient or yourself. But they help advance treatment. So how do they help advance treatment? This is two publications that came out of EIMD, which is a broad-based, lots of patients. And this is how far the spectrum is in individuals with organic acidopathies and urea cycle disorders. That's part one. This is part two, and that's how people progress. All right? Or the natural history of propionic acidemia. This is a questionnaire. This was a questionnaire of patients. Or the impact at age of onset and newborn screening on the outcome of organic acidemias. How does newborn screening help people going forward? These are all registry data. This is where they get these numbers, right? Or the dietary practices in IVA, a European survey, right? So this is all based on registry data. As I said, most of this is the European data. But that doesn't mean that we can't help us all take care of patients. So our registry, so I'm going to switch over. I'm now going to be my NORD, or I'm going to be my OAA person. So our registry is sponsored by the National Organization of Rare Disease, or NORD. NORD put together a series of registries for individuals with rare disease. OAA is one of those places that have received funding and helped sponsor it. You, as the caregiver or patient, put in the data. I, as the physician, can only put in that data in the second version if I'm invited by you. Okay? You participate in the maintenance and next steps. So let's say you do the survey and you go, they should have asked us about that. Who do you go? You go talk to Kathy, you talk to me, you talk to some other people, and you say, dude, this is really important. Why isn't this in here? And so in the next reiteration, we can make sure that that is important. But this is your registry. So what can a registry do for us? Well, it helps us figure out frequency. How common is this? Is there any hot spots in the country? Are there any hot spots in the world? What's the variability? Because remember, the common person with IVA doesn't necessarily get published. Are there any comorbid conditions? How did we figure out that cardiomyopathy or long QT are common in PA or renal failure is common in MMA? Well, it's because patients had it, right? And if you had more than one case, you said, oh wait, this might be common. But how about a questionnaire? We may not know what's common because I may have one patient and Holmes may have one patient and Chuck may have 3 patients with these disorders, but we may not actually realize that it's more common than we think it is. It helps pre-condense expertise, patients, and caregivers in one site. So it allows us to identify complications, identify the medications and supplements that are used. So I don't know if anyone saw that. Recently there was a paper taken in a survey of individuals with parents with Down syndrome. Anyone see this survey? Probably not. It wouldn't be. So there are, on average, individuals with Down syndrome are treated with 8 supplements, of which their physician knows of half a supplement per patient. Trust me, I don't necessarily know everything my patients take, because if they don't tell me, I don't know. It also gives us dietary history. It may allow us to do natural history, looking over time and the progression. It may allow us to do frequency of disease, but we have to have a lot of coverage. It may allow us to do timing and complications, but again, we need lots of people. And it may allow us some genotype-phenotype correlations. It may also allow us to work with these companies that are sitting out there and sitting in the back of the room in terms of helping them do the natural history studies that are necessary for us to get new therapies for our patients. So when Chuck was talking about new therapies, one of the big issues is you need a good natural history study to be able to do drug discovery programs in rare disease. When it's a limited small population, that natural history study is a lot more complicated. So what is in our registry? Demographics, that says where you are. Presentation history, so what you presented. For the adults in the room who have these disorders, you may want to have your mom or dad help. Because last time I checked, you don't remember when you were born. Most don't anyways. Admissions data, growth data, developmental data, and that's a series of questions that will be asked once a year. Immunization data. So we talked about how preventing infection is essential. Immunizations are essential, and this helps us kind of